So today in this lecture, we'll be discussing about tyrosinemia. So as we know, tyrosinemia, there are three types of tyrosinemia: tyrosinemia type 1, 2, and 3. Type 1 is the most important tyrosinemia as far as clinical medicine is concerned because it affects liver as well as kidney, and it presents in the childhood stage itself. And if left untreated, it can cause catastrophic outcomes. Type 2 and type 3 are called oculocutaneous tyrosinemia because it affects mainly skin as well as eyes. We don't discuss those two topics here. We discuss only type 1 in this lecture. This is the phenylalanine tyrosinemia pathway. Phenylalanine, through the action of phenylalanine hydroxylase, gets converted to tyrosine, and tyrosine undergoes a series steps of form its metabolism and finally gets converted to fumarate and acetoacetate. The importance is that before fumarate and acetoacetate are formed, fumarate acetoacetate, that's an alkylating compound. So if it gets accumulated, it will result in toxic injury to kidney as well as liver. Hepatocytes and renal proximal tubules are the only organs which express this complete pathway. That's why liver and kidney are commonly involved in this disease. And the normal range of tyrosine is around 30 to 100 micromole per liter. Coming to the topic proper, that is tyrosinemia type 1. So in this, if you see, the pathophysiology happens due to deficiency of this enzyme, that is FAH, fumarate acetoacetate hydroxylase. So what happens due to the deficiency of FAH, fumarate acetoacetate and mallyl acetoacetate gets accumulated. It goes into an alternate pathway. Succinyl acetoacetate that then gets converted to succinyl acetone. I'm sorry, succinyl acetone is the biomarker and not succinyl acetoacetate. So mallyl acetoacetate and fumarate acetoacetate through a series of steps gets converted to succinyl acetone. Succinyl acetoacetate can inhibit the heme degradation pathway. So if there is accumulation of succinyl acetoacetate, there can be symptoms of defects in the heme metabolism pathway, which is also known as porphyria pathway. Tyrosinemia type 1 is also known as hepatorenal tyrosinosis type 1. And as we already discussed, fumarate acetoacetate and mallyl acetoacetate are both alkylating agents and it can cause cell damage. In the metabolic picture, you see high levels of tyrosine in all cases of tyrosinemia. However, per se, tyrosine is not a damaging metabolite. It's the intermediates which gets accumulated causes the organ damage. So if we have to find tyrosinemia at birth itself, we can do newborn screening. So what will we see in TMS? We see increased tyrosine. We can even measure. So in NBS, we do measure tyrosine, which will be elevated in tyrosinemia. In DBS, we can also measure succinyl acetone as well. We can confirm the finding of NBS using plasma amino acids assay, that is done usually by a technique called HPLC, and we can test for urine SWAC. If it is positive, if the confirmation is done, we can start nitisinone, which is also known as NTBC. The advantage of starting nitisinone in the early life itself is that the risk of hepatocellular carcinoma, the dreaded complication of tyrosinemia, decreases to 1%. And always there is a caveat that tyrosine is high in prematurity and those children who are on TPN. So always consider these as possible false positive causes. And tyrosinemia usually present in infancy itself, 36% present in the first 2 months. The usual presentation will be hepatomegaly with or without splenomegaly. There will be failure to thrive. There will be icterus. There can be signs of liver failure. When we do the routine investigation, we get signs of liver failure, that is increase in serum bilirubin, increase in PT-INR, increase in ALT and AST. There may be features of renal tubular acidosis like features of rickets, polyuria, and as always, AFP will be increased as there is liver damage. And sepsis can cause acute hepatic crisis. So sepsis can precipitate this presentation early. So you might be knowing that we have a drug now for tyrosinemia, which is known as nitisinone. Why nitisinone is important? It can prevent the clinical symptoms of tyrosinemia. More importantly, it can practically prevent all cases of hepatocellular carcinoma if the treatment is initiated in the infancy itself. So that's where the advantage of newborn screening comes. So if you see this table, if you start the treatment before 1 year, the chance of hepatocellular carcinoma is just 1%. However, if the treatment is delayed, the chance shoots up to 35%. So that's the importance of newborn screening in tyrosinemia. So the dictum is, once you diagnose tyrosinemia, start the treatment as soon as possible so that we can avoid complications like hepatocellular carcinoma. And sometimes there can be porphyria-like crisis, especially in untreated tyrosinemia, or in which there is treatment default. So the child was on nitisinone and then nitisinone was stopped. So there can be porphyria-like crisis. Why there is crisis? It is because succinylacetone can inhibit enzymes in the porphyrin degradation pathway. So there can be porphyria-like crisis. Cardiomyopathy is a rare complication reported in some case series. However, we hardly see cardiomyopathy. In USG, we see nephromegaly or nephrocalcinosis because of renal involvement. There can be liver cirrhosis and regenerative nodules. And HPLC is one of the fantastic assay which will clinch the diagnosis. There will be increased tyrosine and increased methionine. And GCMS can give succinylacetone levels and 4-hydroxyphenyl pyruvate and 4-hydroxyphenyl acetate elevated levels. I'm not going to genotype of the disorder. Coming to treatment, the treatment is simple. We have to restrict tyrosine and phenylalanine in diet, and the silver bullet is nitisinone. Nitisinone is a repurposed drug. What it does is that if you go back to this pathway, it inhibits 4-hydroxyphenyl pyruvate dioxygenase. So if you inhibit this enzyme, the accumulation of mallyl acetoacetate and femoral acetoacetate, the alkylating agents, won't happen. So what will happen? So we are diverting the production of alkylating agents, so there won't be any organ damage. However, because of starting nitisinone, there can be tyrosine accumulation. So tyrosine accumulation can cause corneal crystal formation and photophobia. So these two are reversible side effects. So at that time, we may have to reduce the dose of nitisinone for some time. And nitisinone is a very well tolerated drug. The dose is 1 mg per kg per day in 2 divided doses. If there is acute liver failure, we may have to give double dose, 2 mg per kg per day for first 2 days. Then we can decrease it to 2 mg per kg, 1 mg per kg per day. For older children who is above 40 kg, we can even consider dose based on body surface area, that is 35 mg per meter square per day. Even in adults where the body weight shoots up above 40 or 50, we can modify the dose based on trough levels. We can measure the drug concentration in the early morning before the drug is given, and we have to maintain the nitisinone level in between 30 to 70 micromoles per liter in blood. So we don't have to increase the dose every now and then according to the weight. Once it reaches 35 mg or 40 mg total dose per day, then we can measure the trough levels and we can adjust the dose. The management of tyrosinemia is a kind of success story because nitisinone was previously not available in India. We had to import from US, and obviously you know that when we import something from US, we have to give the import duty, and the price will be more. It used to cost one packet of Nitisinone of 60 tablets used to cost some 70 to 80,000. However, now Nitisinone is made in India. Now one packet will cost 20 to 25,000. So the cost has come down to 33% of the initial cost. The take-home message as a clinician is that always suspect tyrosinemia if there is an unexplained liver failure in a child, and look for signs of renal tubular acidosis or rickets, because that will be present in tyrosinemia, so that there can be high index of suspicion, and send a TMS or measure urine succinylacetone. Urine succinylacetone is a very specific marker for tyrosinemia. If that is present, please start the treatment immediately. Give supportive treatment for liver failure. Once nitisinone is started, liver failure will improve, and keep the child under follow-up. You may have to give treatment for renal tubular acidosis using urinalyzer or bicarb support, etc. The important thing is that if the treatment is continued properly and periodic MRI is taken to monitor for hepatic lesions, the quality of life will be good, and earlier you start the treatment, better the outcome. That's it for this lecture. So if you have any doubts, please you can mail me. The email ID is doc.sarath@hotmail.com. Thank you.